Okay, good afternoon, everyone, and welcome to the weekly Independent Sage briefing. Now, on Monday, the government will remove all legal restrictions on social distancing. What some have described as Freedom Day will, for others, be a day that begins an indefinite period of fear and uncertainty as they struggle to ensure their own safety and the safety of their families during the coming months. Many voices from the scientific community have spoken out against these plans. We'll be discussing some of those concerns today and answering your questions about what can be done to mitigate some of the risks as we enter this third wave. As ever, we have a lot to get through, lots of questions coming up, but we're going to start with the latest figures from Dr. Kit Yates. Kit, over to you.
Great, thanks, Jim. Let me just share screen. Okay, hopefully you can all see that. So yeah, I'm going to do a little bit of a longer presentation today, maybe around 20 minutes or so. We're going to look into testing because we don't always talk about testing, but at the moment it's absolutely crucial that the testing system, test, trace, isolate, is working well. Then I'm going to move on to looking at cases and the consequent impact that that has on schools. And then I'll talk about hospitalizations and deaths and finish by looking at vaccination and how we're doing with that. So firstly, to testing, which is something we don't always bring up every week. This week, we've seen a lot of evidence, or a lot of anecdote rather, from people suggesting that they're struggling to book tests in a variety of different areas. So this is one screen grab for the whole of England, but then if you drill down into different regional areas, this is the northeast where cases are particularly high. There's very few available in Middlesbrough, none in Stockton-on-Tees. Now this changes throughout the day, but people are going and finding that they are not able to book a test. So this is another one from Yorkshire and Humber. Again, South Humberside seeing very few tests available. So this isn't great news. If we can't get people tested, then we firstly have difficulty interpreting what's going on in the case numbers. We will be missing people and seeing fewer people testing positive than we might expect, and that will bleed through into the positivity data as well as just the case data. People might start switching to using lateral flow device tests, which we know give a high rate of false negatives, and so people might not be isolating when they need to as a result of that if they can't get a PCR test. Also, if people are struggling to follow up a lateral flow device test with a PCR test, then they don't know whether they should be isolating, whether it's a false positive or a false negative. So it's not good from an infection control point of view, as well as looking at the data. And certainly without a positive test, people might not know whether to isolate or not. And finally, something which maybe isn't talked about so often is that people with long COVID already struggle to get seen for their condition, get referred to clinics. And that will become especially difficult if they can't even prove that they've had COVID in the first place. So lack of testing has an impact in all sorts of ways. And I really hope that we're not going to see the sort of fall over in testing that we saw back at the start of September when children went back to school and it was very difficult to get a test. Unfortunately, if you look at the recent test and trace data, this is from the weekly report that they put out, this is the median time in hours from taking a test to receiving the results. Now, it's always lower in these blue curves when you go to a local testing site because you don't have to rely on the post to send that test to the lab. But you can see it's starting to rise even there. But if you're looking at home testing kits, for example, on this black dashed curve, you can see that there's been a marked increase recently in the time it takes to receive these test results. And so it indicates that the system is coming under pressure. And again, the longer it takes to get a test, the longer people are out in the community not realizing that they may be positive, the more people they might spread COVID onto. So it's really important that these times get brought down again and that we increase testing capacity. We've seen reports that test and trace are having to rehire many of the people they let go recently in order to cope with the demand on the system. Another thing that's related to testing is how do people know whether they should go and get tested? Well, the government website suggests that you should get tested if you have these symptoms, and the 3 symptoms it gives are a new continuous cough, a high temperature, and a loss or change in your sense of taste or smell. And in fact, this is the same on the NHS website. If you look up what the symptoms of COVID are. In reality, though, we know that the range of symptoms are far broader than that. It includes things like a headache, blocked nose, fatigue, weakness, muscle pains, runny nose, as well as loss of taste and smell, sore throats. These are the things that the European Centre for Disease Prevention lists as their main symptoms. And so people may have these symptoms and think, oh, well, it's just a cold, and not get tested. And again, that's really not good news in terms of getting people, finding cases, encouraging people to isolate, contact tracing people who have tested positive, because people aren't getting tests and are not going to be therefore testing positive. So I think we need to be expanding the list of symptoms that we see on both the NHS website and the government website, especially at a time when we are trying to battle rising cases and we're removing many of the restrictions. Test, trace, and isolate is something which we could do, which is not restrictive, but we're not giving ourselves the best chance of doing that by limiting the definition of the symptoms of COVID. So that's a bit about symptoms before we get onto the other data we usually cover. So now we're going to talk about cases. So this is the case data up to yesterday for number of confirmed cases in the UK. The green is the cases by reported date. Black is the 7-day rolling average, and you can see the rolling average is up above 40,000 a day, and yesterday we had almost 50,000 cases reported. So this is the highest level we've seen since late January, and in fact there were only 15 days across the whole of the pandemic in the UK where we've reported more cases than we reported yesterday. So this is the direction in which we're traveling at the moment. Again, if I just zoom in on that, you can see it's relatively rapid, but looks linear increase at the moment in the number of cases. This is cases per 100,000 people by specimen date, so date people took the test for the 4 home nations in the UK, and you can see that 3 of the home nations, England, Wales, and Northern Ireland, are rising rapidly. Scotland in blue is actually falling, potentially as a result of the fact that their schools have been broken up for a few weeks now, and so we're seeing the impact that schools have on transmission in Scotland. We might hope that we will see something similar in England when schools break up. There's been a lot of talk about this sweet spot, but of course we are also then further relaxing restrictions on Monday, 3 or 4 days before most schools break up. So that's the cases. Just to make sure that it isn't people increasing the number of tests that are being done. It's not just cases, it is there in the positivity data as well. So if we divide the number of cases by the number of tests being taken, we're also seeing that the positivity rate is going up. And in all nations, it's above 5%, which is not good news. According to the World Health Organization, we would like to be below 5%. And ideally even further below. Again, you can see that although Northern Ireland, Wales, and England are all rising, Scotland's positivity has started to fall, albeit from a very high rate, above 10%. And if I zoom in a little bit more, you can see the recent trends in the 4 nations in positivity, with Scotland just starting to come down, and hopefully that will be continued, although their schools are due to go back much sooner than the English schools. Drilling down into English regions, this is cases per 100,000. You can see that cases are rising in all regions without exception. In particular, in the northeast, cases have just gone absolutely crazy. And again, it's not just a result of testing. You can see this in the positivity data as well. Cases in northeast, which is indicated in red here, the positivity rate is up around 15%. So that's absolutely enormous and quite alarming, I think. again, if you look at cases broken down by age now, so this is again by region, but this is for under 20s, you can see that under 20s are rising in all regions, except perhaps for the Northwest, which is interesting because we know that, as you can see from the blue curve here, their Delta epidemic, their Delta wave came before the other regions. So it's interesting to see that Northwest has sort of leveled off recently. We'll have to keep watching that to see if that continues. But there's no sign of abatement in the other regions. And again, the Northeast is showing these particularly high rates in younger people in red here. Looking for between 20 to 59-year-olds, that's the next age bracket upwards. Again, we can see similar sorts of numbers and similar sorts of patterns in terms of the increase. Again, the Northeast is seeing rapid rises, has the highest number of cases per head of population, but it's similarly rising in all the other regions, and it has slowed down slightly in the Northwest in this dark blue curve, but it's not yet plateaued as it has in the younger age region. So again, we need to try and reverse this, but it doesn't seem like that's going to happen anytime soon, given the lifting of restrictions. Perhaps the most worrying age profile is for the over 60s, where again, we're seeing big rises. Now, I want to make it clear that the y-axis is different here, okay? So these are not the same sorts of numbers as we were seeing for the 20 to 59-year-olds, where we're up at 1,000 cases per 100,000. These are much lower here, but still we're seeing rises in this age range. And this is the really worrying age range, of course, because this is the age range who are likely to suffer the most severe consequences of being infected with COVID. So, so I think this is probably the most worrying of those three age charts for me. So moving on to talk about cases, but thinking about their impact on schools now. This is the number of pupils in state schools in England who have been isolating for COVID-related reasons since schools went back on the 8th of March. So you could see there was a sort of steady rise up until the Easter break, and that provided a bit of a fire break. Things reduced then, and then there was a rise again, slower rise up to half term, when we were still under some level of restrictions. And then since we released restrictions on the 17th of May, and we've come back after half term, and we've seen these astronomical rises in the number of students missing school, up to over 800,000 students missing school on the 8th of July last week. And that is only going to get worse next week. And I suspect we'll see over 1 million pupils self-isolating next week, which is not just incredibly disruptive for parents who have to look after their kids, but of course it's incredibly disruptive for children's education and for teachers and for everything that the government has said that they are prioritizing, keeping children in schools. You know, at the moment, we've got over 10% of primary school children and about 13% of secondary school children missing school because of COVID-related reasons. So if you break this down, this 824,000 figure for the total number of pupils who are absent, if you break it down by reason, about 40,000 were confirmed cases, 35,000 for suspected cases, 16,000 because the whole school was closed, and we're hearing more and more reports of schools being closed. And then, of course, the vast majority because of being a contact of someone who's infected. Now we're hearing that when schools go back in September, children will no longer need to isolate, test and trace might be taking over that role, although how they will identify close contacts is beyond me. But really, stopping children self-isolating is not fixing the root cause of the problem, which is high levels of community transmission of COVID in the community and in schools. We could be doing things like putting in better ventilation, mask wearing, other mitigation measures to stop the spread of COVID in schools, but instead we're sticking a plaster over it by stopping children from isolating, which will no doubt then increase the rates of COVID in schools. These are the week-on-week increases from last week for primary schools on the left here, so up from 328,000 to 434,000 isolating, and in secondary schools slightly lower, but an increase of around 90,000 week on week. And again, just looking at the percentages, so the green bars, which correspond to the right-hand axis here, primary school pupils have been literally decimated, 10% of pupils missing school last Friday. And for secondary schools, it's even worse, up at around 13%. So huge numbers of children missing school. And for me, partly having been a parent who's been looking after a self-isolating child, but I think it's incredibly disruptive, and it's appalling that this is happening to our students, to our pupils, to our children, after we've been told so often that education for children and children in schools is the absolute priority. We're not prepared to do even the simplest things to mitigate transmission in schools, to make sure that children can stay in schools. And this is just looking at the number of cases per 100,000 by age group. Again, 0 to 4 in blue, 5 to 9 in orange, 10 to 14 in grey, and 15 to 19 in yellow. You can see primary school rates of COVID are actually lower than secondary school children, as you might expect, but they're all rising, and in particular secondary school children, represented by the yellow and the grey bars here, or charts here, are particularly high and rising. So that's school related data. I'm going to move on to talking about hospitalizations, because much has been made of the idea that there's the link between cases and hospitalizations has been broken. So you wouldn't expect to see rises in hospitalizations if that were the case. Of course, the link has been weakened, but it hasn't been broken. So if you look at new hospital admissions in England up to a couple of days ago, you can see that ever since around the beginning of May, we've seen rises in hospital admissions. Those rises are starting to accelerate, reflecting the acceleration in cases maybe a week or so, maybe a week or two before. So we're seeing rises in hospitalizations, and they're going to continue for the next few weeks as cases continue to rise. And remember, there's a lag between cases and hospitalizations. This is broken down by region in England. This is the 7-day moving average of the absolute number of cases. So it's not normalized by the size of each region, but you can see that rising most quickly recently has been the Northeast and Yorkshire, this red curve again, which reflects the rises in cases, and that's going to get higher and higher. So all regions are rising. There's no region in England which is special for some reason, which isn't being impacted by the rises in cases. And then this is hospital occupancy across the whole of the 4 nations of the United Kingdom. So you can see, I've put it on this long time from all the way back to September, so you can see where we got to in November and then in January and February. We're not at the levels where we were, but I want to point out that that's an incredibly low bar to set, because actually in January and December and January, hospitals genuinely were overwhelmed with COVID patients, and there was little room for doing anything other than COVID in hospitals. We don't want to get anywhere near there, but we are rising and we're heading back towards there. So we would really like to avoid that from happening. So you can see, if I zoom in a little bit more, that we are as high as we've been in England since the end of March, and certainly in Scotland, where cases were rising more quickly since around the middle of March. And we obviously would like to slow this down and to stop this from happening, because when pressure gets put on the NHS, we have to cancel other operations, normal routine care for people. And that's something which we would really like to avoid doing, obviously. And then finally, before I talk about vaccinations, deaths. So it would be great, again, if deaths were completely eliminated, if the link were broken. It isn't quite. Again, you can see we're not at the same levels of deaths as we were back in January. But again, we really don't want to get anywhere near the sort of average of 1,200 deaths a day that we were seeing for COVID-related reasons. You can see the rise here. If I zoom in a little bit more, you can see that ever since the end of May, we've been rising. And yesterday we announced 63 deaths, which is the highest since March. So these figures will continue to climb for the next 3 or 4 weeks, reflecting the rises in cases that we've had to date. And if cases continue to rise, then deaths will continue to rise after that date as well. And so I'll finish with vaccination data, which for so long throughout January, February, March, April, May has been the good news section of the story. But unfortunately, vaccinations really slowed down almost ever since the government announced they were going to delay the stage 4 of the roadmap to be the 19th of July rather than the 21st of June. We've seen falls in the number of vaccinations being given at a time when we bought ourselves 4 weeks of time to try and up the vaccination rates to protect as many people as possible, and vaccination rates have just been going down and down ever since, unfortunately. And that's partly because we're nearing the end of the vaccination program, or first doses at least, for younger age groups, but it's partly because people aren't taking vaccination up with as much vigor as we'd like them to, and there's suggestions also of supply issues. But it's sort of unsurprising if the government sends the message to you that it's okay if you're a younger person to get immunity through natural infection rather than through vaccination. Why would you bother going to get a vaccination? And we need to change that message, because the best way for people to get immunity from infection is to get vaccinated, not to risk getting COVID and all the attendant consequences that can come with it. So in terms of looking at the percentage of the total population who've been vaccinated, in England, we're about 53%, but that still means that 47% of the whole population have not had 2 doses of the vaccine yet. And that means that there's a large number of people who aren't being offered the best protection. The picture is similar across the other 4 nations, although Wales is doing rather better. Again, looking at first dose coverage, this is now as a proportion of adults. These figures make it look fantastic. So 90% of adults in Wales have had their first dose, 89.2% in Scotland. So these are really good figures. But we need to remember that this is not a percentage of the whole population. We're not at the moment offering vaccination to children, and so these figures that I presented on this slide are slightly more relevant in terms of if we're thinking about achieving herd immunity and protecting the whole population. Again, these are second doses, and again, it looks good as a proportion of the adult population, and it is still continuing to rise, which is good. We're not seeing the same leveling off as we have with first doses as we reach the sort of capacity that we expect. And so hopefully this will continue to rise over the next few weeks. Breaking down by age category, you can see that, well, everyone over 18 now has been offered their first dose. There will still be a bit of a lag before younger age groups have time to actually take that up. But we are seeing, if we look at the blue bars here for first doses, we are seeing drop-offs as we get down to younger age groups, which are not just related to the fact they haven't had the chance to take it up. It's related to the fact that these younger age groups are not taking up the vaccine in as high a proportion as we might have hoped. Again, the last thing that I want to focus on, and I do this most times when I do the vaccination coverage because I think it's really important, is if we break down vaccine coverage by ethnicity, you can see there's clear disparities by ethnicity from white people who have up over 50s who've taken up the vaccine with a rate of 94%, down to black over 50s who've only taken it up with a rate of 69%. Similar picture for second dose coverage, although it's even worse now, and all over 50s should have been offered their second dose. So we're seeing fewer people take up both doses than just the first dose. And then if you look by all people, all adults rather, all over 18s in England, again, you can see that these rates are even lower, and there's still this clear disparity. These figures will increase a little bit over the next few weeks, but you can see there's a clear disparity in uptake, which we really need to battle, lest we leave some sections of society less protected from COVID than others. So I'll finish by saying that cases are rising rapidly in England, Wales and Northern Ireland. It's not a particularly pretty picture. Fortunately, cases are falling in Scotland, probably as a result of the fact that schools have broken up there. We saw high case rates in the under 20s, but also in the 20s to 59s. And perhaps most concerningly, in the over 60s, we're starting to see increases, although the absolute rates are a little bit lower at the moment. In terms of schools, 800,000 children missed school on the last day of last week, on the 8th of July, for COVID-related reasons. Some schools were closed, some children had COVID, the vast majority is children who are isolating. That is significantly impacting on children's education, and it's causing disruption to parents and children. It's not good for teachers, it's not good for anyone, in short. Hospitalizations are rising across all nations, and we've already seen that some hospitals have had to cancel routine care as a result of increased pressure due to COVID. That's going to happen more and more often as hospital occupancy continues to rise. Deaths are also starting to rise more quickly now, and we saw the highest reported figure for deaths since March yesterday. Unfortunately, vaccination at a time when we really need it is slowing down massively, and we really need to focus on trying to get as many people as possible 2 doses. So the window for getting your second dose has now been shortened from 12 weeks to 8, so you can rebook. I just managed to rebook mine yesterday, so I'm getting my second dose next week rather than the middle of August, and the more people that can do that, the better. So let's make sure everyone has the opportunity to be vaccinated as we open up. And I'll finish there and pass back to you, Jim. Thanks.
Thanks very much, Kit. Before we move on to questions, a quick one that occurs to me that you didn't mention in your data when you did a breakdown in age and ethnicity of uptake of vaccine. Am I right in thinking that breakdown by gender, particularly among the young, is quite stark? Men are something like between 5 and 10% less likely to take their first dose of the vaccine than women. They equalize, they sort of get to equal pegging in older age groups, but among the young, is there an obvious explanation for this?
I haven't seen the latest data on that, and no, I don't. Unfortunately, it's probably beyond my remit to try and give an explanation, but perhaps the behavioural scientists in the group might have a better idea of why there's this disparity by gender in younger generations.
I mean, yeah, Susan, I mean, I hope I'm right in saying this. I'm not making it up. I think I saw something there.
Well, one thing we know from the data is that younger men have been the least likely to adhere to restrictions all the way along of all groups in society. So it may be that they don't see the risk as high as other people, but it would be consistent, with not taking a precautionary to things.
Isn't it just that boys are a bit useless compared to girls?
I think that's what I was going to say. It's less intelligent. I think the intelligence rises as you get older and you almost reach sort of the women's proportion, but among the young, it's
not only intelligence, Jim, it's emotional intelligence. It's everything. Boys are a bit useless compared to girls.
Unfortunately. Okay, right. Well, back to more serious matters. So come to the questions. The first question comes from William Manners, and I've been asked to read it out myself. William says, I don't agree with the government strategy. I'm assuming this is about the opening up on Monday, but is there a utilitarian argument for going ahead with the 19th of July? I don't know, maybe Christina or Gabriel?
Well, I guess my answer to that is no. I mean, I don't think there is, and I feel like we've set out the reasons why over and over again, and there just isn't a choice between health and wealth. It just doesn't. It's not there. The best way to get utility for our population is to get COVID to very low levels, and we're not doing it. So that's my answer.
Gabriel.
Jim, thank you for that. I mean, I'm assuming you mean the principle of the greatest good of the greatest number. And I've never found that particularly appropriate to my practice as a public health doctor. Otherwise, I wouldn't pay much attention to the people who are least well off, the people who are most ill. That's not the way we do things in this country anymore. What we try and do is achieve maximum health for everyone. That's just what we do. We don't let others fall by the wayside. We try and help them, and we try and protect them.
Yes, Susan.
There was an excellent study published in The Lancet, which compared OECD countries that had taken an elimination strategy, which was, an initial, in some cases, lockdown, and in other cases was various kinds of restrictions, compared to the countries that hadn't done that. So the first group included Australia and New Zealand, for example. I think there were 8 countries pursuing that. And what the study showed was that those that were pursuing an elimination strategy not only had better outcomes in terms of health, so both disease, disability and death, but also the economies were less harmed, and also it was better in terms of overall restrictions. Those countries actually, even though they may have used lockdown at the beginning in a very strategic way, had much fewer restrictions over the course of the pandemic. And some of us were speaking or watching an hour-long conference just an hour ago, which is on, if people are interested, it's on Twitter and All the Citizens Twitter feed, which brought together people, leading scientists from all over the world, talking about their perspective of what's being proposed on July the 19th. And I say they just repeated, I mean, in person, the results of that study I mentioned, by really showing that actually, you know, when you say about utilitarian, it's almost like trade-offs between different things, that you know, if we want to prevent maximum harm and future lockdowns, it's a question of doing strategic restrictions at this point in the pandemic.
Thank you. Anthony, did you want to quickly come in?
Sorry, yeah, just very quickly on the greatest good for the greatest number, I would argue very quickly that we know from actually a paper that Susan was on that only about 20% of people with COVID symptoms are getting a test. So you could multiply Kit's figures of, say, 38,000 cases in school children by 5 potentially, because you know that it could be many more. Secondly, if you look at long COVID, we know that children in the secondary school age group, about 14%, so about 1 in 8 almost of children will have long COVID symptoms. We don't know what the long-term effects are. Long COVID is really nasty. You get all kinds of symptoms. It can go on a long period. So that's the second thing. Thirdly, older people who have been double vaccinated get breakthrough infections. And letting it rip through the population. I'm a case in point. I got COVID 3 weeks ago. I still have some symptoms, and it was a breakthrough even though I was double vaccinated. And finally, if you have everybody getting the infection, the immunity you get from the infection is about half as good as you get from vaccination. So the utilitarian principle would be keep community infections under control, get all people vaccinated, including children down to 12, and then you can you get a much better result in the utilitarian sense. And the child vaccination story is interesting because although they're delaying and saying they're not sure and it's not really that big a problem, I actually think the real reason is that they don't have adequate supplies of Pfizer and Moderna. And I think we have a supply issue at the moment, which is why they're not giving approval to go ahead with younger children.
Thank you. Okay, our next question comes from Emmy Kelly. Emmy, I see you're here. Do you want to unmute yourself and turn on your video and ask the question?
Hi. Many of our CEV feel like Freedom Day is Incarceration Day for us, forcing us back into shielding, although many haven't stopped shielding with very little support. Shield Us supports thousands on our shielding community across the UK. We're hearing a lot of fear and anger. Many are now making peace with the fact that after shielding for 18 months, given the Delta variant and proven mitigations like masks being removed, it's putting us at higher risk of contracting COVID, given we are at the highest risk of death from COVID. Our numbers are growing every day. Many are immunosuppressed. Our numbers growing through new diagnosis. Until proper safety measures are put in place to reduce transmission, we need a full financial, practical and emotional support package. My question is, what do you think our shielding community need for support right now?
Zubaida.
I am so sorry, Emmy, that you are in this situation, you and approximately 3.8 million extremely vulnerable adults, but also extremely vulnerable children. And vulnerable children have been put in this appalling situation. It's absolutely reprehensible that the government has thought of this strategy and gone ahead with this strategy, and they will go ahead, I'm sure, next Monday without carrying out any impact assessment on extremely vulnerable groups. And it's shocking, given that the whole vaccination program was all around the vulnerable first, the elderly first, the vulnerable groups first. It's shocking that the government have overlooked your groups, both in terms of adults and children. And I think they are already facing a big a big sort of reaction to that. We know that people from the left and the right, from all groups, from all of society, are really reacting to the notion that people who are extremely vulnerable and clinically vulnerable need to just stay indoors, need to stay away from unvaccinated people, as though they don't have unvaccinated children, adults, children, carers, relatives, or anyone else, you know, visiting them or anything else. That idea is terrible. So hopefully the government will now think much more clearly about what needs to happen. As my colleague Anthony Costello has said, that means bringing cases down. That means rolling out vaccination to the other 48% of the population that are not fully protected. And that also means that everybody is protected in society rather than just a few. And if they do continue and they do say that you have to shield, then we would expect them to provide financial support, we would expect them to provide mental health support, and we would certainly expect them to vaccinate all the children, clinically vulnerable, as well as those who are in clinically vulnerable families.
Thank you.
Thank you, Zubaida. You wanted to add something, Anthony?
Yeah, it's very quickly. I completely agree with everything that Zubaida said. But, you know, this is worse than dangerous. I mean, you've got very vulnerable children, as you've said, and there is a vaccine that has been approved by the medical regulator, but you can only get the vaccine through the NHS for free. And I've had several letters this week from people saying, you know, can we go privately? We'll pay to get this vaccine. And of course you can't. So the government is actually prohibiting vulnerable children from getting access. And they should be very high priority. I mean, they would be the #1 group to go for. And so I find this, I think the word is reprehensible. I just cannot find any medical justification for this whatsoever. And it is a dereliction of public health duty, in my view. And I feel really sorry for you, Emmy. I mean, it's outrageous.
Thank you.
Thank you for your answers. Emmy, thank you very much for a very important question. The next question is from Keith Ferguson. Is Keith there? Yes, you are there. Hi, Keith. You're still on mute, though, but welcome.
Unmute at the moment. There we go. I've heard it's a suggestion that while vaccination will give us a high level of personal protection, possibly some 90%, its impact on transmissibility will be much less, so that vaccinated individuals will still have only about maybe a 50% reduction in the likelihood of passing on infection. Is this correct? Because if so, it seems to me the implications are profound.
Carl, I think probably you're best suited.
Yeah, that's an excellent question. Obviously a very, very timely question. So there are two ways of assessing the efficacy of vaccination at various levels. You can look at people who have and have not been vaccinated and compare the risk of being PCR positive, for example, or being hospitalized or dying, and compute the efficacy in terms of what's called a sort of an odds ratio or a relative risk. And those analyses and studies do return the kinds of figures that you have quoted. You have to make certain assumptions, though, in the sense that if you evaluate the risk of being PCR positive if you have not been vaccinated, you have to then assume, well, what is the probability of then getting sufficiently having a sufficient illness that would cause you to be infectious and thereby transmit it onto somebody else. So that speaks to another way of estimating the efficacy, which is the kind of modeling that we do, or I do, which tries to estimate the various levels of efficacy that best explain what's actually happening at the moment. And that allows you to drill down on the various stages from infection to death that the vaccine operates and evaluate the efficacy. So at the moment, we've looked at the efficacy of the vaccine stopping you getting infected, being exposed to the virus, the efficacy of you stopping you going from being infected to infectious, namely, in the position of being able to transmit it to somebody else, the efficacy of you developing serious illness and the efficacy of you dying if you have serious illness. And the profile was quite surprising. In the sense that it looks as if vaccination has very little effect on stopping you becoming exposed or infected, has a much more substantial effect on you becoming infectious and capable of transmission. So the numbers are roughly 4% and 84%. So the average of that is the 50% number that you've described. What that means, I should just add, the probability of developing serious illness is about 60%, and a very precise estimate of fatality would be in the order of 93 to 94%. So it's very effective at precluding fatality, but it's not going to stop you getting infected, but it will attenuate the probability of transmission, but only by about 1 in 5. So the basic message here is, if you assume that being vaccinated stopped you getting infected and infecting somebody else, that's probably not true. It doesn't have much effect on the probability of becoming infected. It has a substantial but not complete effect on passing it on to everybody else. So the message here is that there has to be, I think, an awareness of that, and that you should probably apply the same precautionary principles in terms of your own behavior as you did before you were vaccinated. You can be reassured that you're not going to develop a serious illness, but in terms of transmitting the disease, there is a non-trivial risk.
Thank you. Kit, you wanted to come in?
Yeah, just in terms of the profound consequences that you mentioned, Keith, I think there was hope that when we brought these vaccinations out, that we would be able to vaccinate enough people that we would be able to achieve herd immunity. So that means having enough people vaccinated that the disease is denied the contact between susceptible and infected people that it needs to pass on. Very basic calculation with this new Delta variant suggests if the basic reproduction number is 6, so each person passes the disease on to 6 other people during the course of their infectious period under no mitigations when everyone is susceptible, that means that you would have to vaccinate about 83% of the population. That's a back of the envelope calculation, but that would be under the assumption of perfect immunity, so no transmission between people. As soon as the effect on transmission goes below about 85%, so it's not 100% effective at blocking transmission, maybe only 85, that means you then have to vaccinate 99% of the population in order to achieve this herd immunity threshold. And so if we're talking about 50% effectiveness at blocking transmission, then we aren't going to achieve herd immunity. That said, that doesn't mean that we shouldn't try and vaccinate as many people as possible, because the more people that have immunity, the easier it becomes to slow the spread down, to control the spread through other non-pharmaceutical interventions like mask wearing, like find, test, trace and isolate. So it's not a hopeless message, but it is a message that we aren't going to achieve herd immunity in the way that we might have hoped with a variant which was less transmissible.
Thank you, Kit.
Could I just leave you with one final thought on that?
Sure.
If that is the case, then that means presumably that the virus can continue to move through the population. And as it's increasingly vaccinated, that gives an evolutionary advantage to any emerging vaccine-resistant variant. Just a thought that seems to concern me a lot, nothing personal, but to do with the population as a whole, and the fact that, of course, along the way, it'll eventually find the clinically vulnerable from the population. Thank you.
Thank you, Keith. Susan, did you want to respond to that briefly?
Just to say, absolutely, you're absolutely correct. And that was a point that was made very powerfully by this leading scientist from countries all around the world at the conference I mentioned earlier today. It is a risk, big risk.
Thank you. I mean, these stark statistics, I mean, they totally fly in the face of the popular perception that I've been vaccinated, I can go about my business come Monday as though nothing's, I'm not going to catch it, I'm not going to pass it on. How we get that message across is a difficult one. Thank you. The next question is from Julia Trewick. Julia. Hello.
Hello. Keith asked part of my question because he was concerned about emerging variants. I live with blood cancer, and I know our charities are doing an enormous amount for us. But what I wanted to know is if the panel had any thoughts about whether the government were breaching World Health Organization obligations, health and safety regulations, and the Qualities Act regulations by their behaviour.
Gabriel, do you want to?
Yes, I mean, the World Health Organization doesn't actually set regulations. There are international laws about infectious diseases, and I'm not sure whether they are in breach of the international treaties or not. That's a very good question. I am very worried about the UK government and employers being in breach of their obligations under the health and safety at work legislation about the provision of fresh air to employees. And by employees, that obviously also means customers in retail premises, etc. I mean, the Health and Safety Executive is very explicit about this on its site. It talks about that legal obligation, and when you look at the regulations, it's there in black and white. Now, COVID-19 must have altered our definition of what constitutes fresh air. It must have. And I think lots of employers are in serious breach of that legislation and regulation. We need to wake up to that, and we need to start doing something serious about the issue of ventilation and the use of better quality filters in all places. So I think, and my one other legal concern is that there are, of course, international declarations of human rights about the right to life. And I would not at all be surprised if international human rights lawyers weren't looking at the policy being adopted by the UK, both in terms of its effect on our own citizens in the UK, but also the effect that we would have in terms of spreading COVID-19 further around the world through the huge growth in cases that's going on. So I wouldn't at all be surprised if those issues of legal liability come into play both domestically and internationally.
Thank you. Christina.
Yeah, I just wanted to add that there might be a way to challenge the government on inequalities legislation that it disproportionately impacts CEV people, and that I mean, obviously I'm not a lawyer, but it's more, I think it'd be harder to challenge the opening as a political decision, but to challenge the government on saying you haven't done enough to mitigate it for this group of people, and take that case. But I think it would have to be done by someone taking a case against the government and following it through that way. But I think it's feels like 4 million people have been hung out to dry, really. So it's outrageous.
Thank you. We've got 3 questions left, 3 people around to ask questions and 10 minutes to go. So if everyone's happy, we'll move on to the next one. Thank you, Julia, for your question. The next one comes from Mick Coffey, or Kofi. Mick, are you there? Have I caught you by surprise? I can see you're probably fiddling with your video and mute. Ah, here we are.
Have you got me? Thank you.
We've got you. Off you go.
All right. Thanks for taking my question. Should there be more mitigation to protect children from long COVID, given they are developing, as it clearly has aggressive and long-lasting neurological impacts, especially as team vaccination seems to be off the table for now?
Who would like to? Zubaida, you're nodding. Did you want to come in on this, and maybe go to Kit?
I would, but I think someone like, Kit's been doing some work on this, and Anthony. I mean, I've got stuff to say, but I'd be happy to bow to them at the moment.
Okay, Kit.
I won't repeat Anthony's points about the reasons why we need to vaccinate children against long COVID, but in terms of mitigations to protect children, yes, absolutely, we should be doing more. We should be doing more in schools to prevent mitigation. We should be doing more in the community to bring down rates of COVID, full stop, which benefits everyone. But certainly within schools, we should be doing more, like ventilation, like mask wearing, to prevent children from or rather to mitigate transmission in schools to prevent children from getting COVID, with the impacts that COVID itself has, as well as the long-term health implications of long COVID. So absolutely, if we're not going to be vaccinating children, then we should absolutely be doing more to protect them in schools where we can.
Thanks, Kit. We have a question from Claudia Hewitt.
Yes, hello, can you hear me?
Yes.
Okay, hold on. Okay, my question really is about the prospect of return to work. I work in a typical modern office building in the city, open floors, no windows, and my employer has already indicated that nobody needs to wear a mask once everybody is to return to the office. We're talking thousands of people in a building. And in addition, I know 3 colleagues that will not get the vaccine, one sitting next to me and one opposite. And also, already raised a little bit earlier, people usually talk about having good ventilation inside of a building. But what exactly does good constitute?
Thank you. Thank you very much, Claudia. By the way, Mick, thank you very much for your question. I didn't thank you, sorry. Who would like to come in and answer? Susan.
Well, I actually heard Professor Kath Noakes from Leeds on the radio earlier today talking about this issue, and saying that the problem isn't about so much with regulation of ventilation at work and in other public buildings, but it's of the inspection and ensuring that workplaces and other public spaces are adhering to the regulations. Now, presumably that's because there's a lack of resources. The government hasn't invested in people to inspect and therefore ensure that there is enough ventilation. When Kath talks about it, she talks about it in terms of there being a throughput of air, but it's a complicated question because it depends on how many people, how big the area is, and what, if you open a window or a door, how much flow is coming in. I do think it's maybe something we could have invite her or somebody onto this program to discuss in more detail. But the other thing that's worth remembering is that there is a way of monitoring, a kind of proxy way of monitoring the quality of the air, which is carbon dioxide monitoring. And some countries, including Belgium, have this spread throughout different establishments. So I think that could be a practical thing you could ask your employer to do. If not appropriate individually, then through your trade union or other collective organisation of staff in your workplace.
Okay, Gabriel.
Yes, a great question about the ventilation bit. I agree with Susan on that. And CO2 is a very good proxy, though it does depend what actually the activity going on is. If you are in a place where there is a lot of shouting going on, a lot of talking, or singing, we know a real problem if you were in a live music venue or something like that. CO2 wouldn't be good enough because there would be just so much virus generated by your exhaled air. So it depends, first of all, on what's going on in the activity. CO2 monitors are very good. They are variable in quality. They need to be good quality. Some of the mandation that Susan was talking about in Belgium involves them in places visited by the public, and that the levels have to be displayed. The current level has to be displayed. And that's the sort of direction we should be going in. Sometimes ventilation is difficult to do, and there are other things you can do. You can put in place relatively cheap HEPA filters, which will, a good filtration system, a good mobile filtration system in every classroom, for example, would make all the world of difference in places where it's not necessarily easy to open windows. But this calls not for me as a public health doctor, it really calls for a heating and ventilation engineering perspective. And we should be, we haven't heard enough from that professional group, and they have a tremendous public health role in this, and they are unfortunately being ignored. And my final point is, as well as all that, you know, we've just heard about how the vaccine doesn't, double vaccine doesn't protect people from being infected, or doesn't prevent them from spreading it on. So we do need to emphasize mask wearing, and we need to take the same principle. This is airborne transmission. We are still, I'm afraid, operating on the basis of it being droplet transmission. So I still see people pulling jumpers up over their, or scarves up over their heads, or dripping face masks made of layers of cloth. That's not good enough. We should be, like other countries, moving to good, standardized, effective face masks available cheaply for everyone, and employers should be providing them free for all employees in places, alongside ventilation, alongside monitoring. That's the program of intervention we need from this government, not telling people that they've got to be cautious. That is absolute nonsense. That's a complete dereliction of duty.
Thank you, Gabriel. Okay, and I think what is probably likely to be our final question is from a journalist, from John Siddle. John, over to you.
Hi, can you hear me? Sorry,
we can hear you fine, yes.
Letting me down today. I'd just like to get, Christina, you just sound exasperated. I'd just like to get, a kind of, just a few lines from you really on how you're feeling ahead of Monday. We've had a lot of the science, but kind of emotionally, and how are you feeling? Is it trepidation, anger, fed up?
How I feel about it? I feel pissed off. I feel and sad and angry, and we're having the wrong conversation, right? Opening up on Monday is madness, right? We shouldn't be doing it. We should be talking about how do we get cases down now. The Academy of Medical Sciences, in a report commissioned by Patrick Vallant, said that at peak we'll be getting 20,000, 30,000 cases of new long COVID happening every single day. What are we doing to our young people, our children, the vulnerable? It's just wrong, right? I mean, that's how I feel about it. And, who knows what we'll be in 6 weeks' time, but it's not going to be anywhere better than we are now.
Anyone else want to vent their frustration, Kit?
I just personally feeling, representing perhaps younger demographic, I've only had one dose of the vaccination. Fortunately, I'm going to get my second dose on Tuesday, but not everyone is that fortunate, and I still won't be fully protected for a couple of weeks after that. And the idea of just allowing this to spread throughout the population, to infect lots of younger people who haven't been given the best protection, we haven't allowed them to have time to get the best protection. After younger people have sacrificed so much during this pandemic for the older generation, kids have missed school, students at university have just had the worst time. It's not been the best time of their life as it's supposed to be. It's been absolutely rubbish. Our younger people have sacrificed so many opportunities, and we are letting them down again. And as Christina says, the conversation shouldn't be about, is it right to go ahead? It's how do we bring cases down now? How do we stop this turning into a long-term health disaster?
Thank you, Kit. Martin, did you want to come in? I know you've had microphone issues, but we haven't heard from you. Then we'll come to Zubaida to wrap up.
Yeah, no, I just share Christina's anger and bewilderment. The one good thing is that the people are ahead of the politicians on this. The polling data, the reason that the government rolled back was that after the announcement that everything would be open and we'd have Freedom Day, then MPs were rightly getting emails and calls from their constituents who were very concerned. They saw the polling data, and I think people are going to behave sensibly. They are going to not sort of tear the seats of the pant of it, or whatever it was Jonathan Van Tam said. So I think that's a little bit reassuring. But here we have a situation where we have a government which talked about data, not dates, has thrown that out the window, has said it was following the science, it has thrown that out the window. And this is actually really bad for democracy, for public health, for governance, for everything else, when you have a government that is issuing such confusing messages, undermining itself in many ways. And this is going to be really problematic when we have another crisis. I'm old enough to have written about the loss of trust at the time of the BSE crisis. And I said, when the government did tell the truth, people wouldn't believe it. And that happened with MMR. We had the problems there. So this has longer term consequences when you behave so stupidly.
Thank you, Martin. Zubaida. I know you had your hand up earlier.
Well, actually, I want to just build on that point that Martin mentioned, which is one of my biggest concerns at the moment is for actually the well-being of society. I am really worried that because the government have created this situation where we have a raging third wave, and yet they've shifted responsibility to individuals, to employers, that there's going to be enormous tension and divisions in society as people are left to figure out what's right, what's wrong, what's safe, what's not safe. And they are going to be tensions between employees, between employers, between individuals on tubes and so on. And there's going to be huge, huge divisions. And I'm really, really concerned about that. It's once again reprehensible that the government are putting individuals and society in that position.
Thank you, Zubaida. Well, it's a shame to end on this pessimistic note, but we are where we are. We've come to the end of the hour, so we have to wrap up. With apologies to those we haven't had a chance to get to them to ask their questions. Can I go to Sir David King to wrap up this meeting?
Thank you, Jim. I think all I'm going to dwell on is that last question. What do you feel about the 19th of July? And this group, extremely hard-working group, totally committed to trying to get the best for this country and its population out of this disease. And I have never come across such a willing group to give their time, in addition to their day jobs, etc., to trying to give advice not only into the public domain, but of course into government. And here we are, much more than a year later, still frustrated by the amazingly poor response that if you like, that we've achieved as well. Is it our failure as well? I think we have managed to reach into the public domain, but I think we seem to be faced with a reality, which is that we're not really going to manage this. So I'm just going to leave you with that, a sense of a wonderful group of people who really have been giving the right advice throughout, and yet we are nothing but frustrated by what we see, the desolation of our health system, but also our economy. So let's hope we can move on.
Thank you very much, Sir David. And thank you, everyone. Thank you to all our scientists. Thank you to everyone for watching. It's true, more and more people are tuning in to watch Independent Sage every week. This is a frightening time. I for one, I'm going to be more cautious come Monday, not less cautious. And this is really why Independent Sage continues to meet and provide guidance on how to stay safe during this ongoing pandemic. Please follow us on Instagram and Twitter if you don't already. And please keep sending in your questions. Stay safe, keep well. Goodbye.
Thank you. Bye-bye.
Bye. Thank you.